I'm very pleased to hand over the proceedings to Dr. Chahin. Over to you.
Thank you very much, Kevin.
Thank you.
Appreciate it. Can everybody hear me okay? All right, so the microphone is perfect. Please let me know. I like to walk around. Please let me know if at any point you can't hear. Interrupt at any time. I'm going to keep this very interactive. I have stops throughout the talk on purpose, or I'm going to stop and let you ask questions before we move on to the next section, so we can talk about it right then and there. And just briefly, I wasn't planning on talking about my fellowship, but my fellowship was funded by the MS Society and it's now called the American Brain Foundation. It was a hybrid clinical research fellowship. Fortunately, I'm not going to talk a lot about, well, some of the research that I did has made it into the slides. But it is, as Kevin said, the MS Society funds a lot of fellowships. Short as being 1 year of just training neurology residents in taking care of MS patients, to up to 3 and 4 years of research. And I was fortunate to receive one of such fundings for 3 years, which allowed me to learn how to take care of patients, but also do the thing that I'm passionate about. So we are going to talk about updates, mostly in research, some of it about drugs. I have wanted to include, let's see if this is well. I did want to include some introduction slides. We won't spend a lot of time talking about MS. All of you in the room know what MS is and how it can affect us. But basically, it is an autoimmune disease. The immune system mistakenly recognizes the brain as something foreign, specifically parts of the brain, and it produces an inflammation response. And then they target the myelin and the nerve axons, and then potentially the nerve cell itself, the neurons. In most of our patients, when MS presents, it's a relapsing course. You get an attack, it should last at least 24 hours, it gets better, you go into remission, another attack, and so on and so forth. Smaller number of patients, it will be a slowly worsening course from the beginning. And in some of those patients that have relapses, 15, 20 years, hopefully never down the line, they'll get into a slowly progressive course as well. We call that secondary progressive. I'm going to talk about the types in a little bit. We don't know exactly what causes MS. That's the million-dollar question. That's where a lot of research is going, because if we figure out this question, then we have our answer. We can just not only treat the inflammation, but we can stop this thing in its tracks. But, like I said, we know more about the risks. We know what's going on behind the scenes. So there's been a lot of research in trying to treat all of those different aspects. And that's why we're at 13 drugs, and that's why there's a lot more coming down the pipeline. So I briefly mentioned these. The first type is relapsing remitting MS. The reason I put this is we're going to touch on them in several slides. So I wanted you to get introduced to them early on. Like I said, about half of these patients untreated, after 15 to 20 years, they'll go on into getting slowly worse over time. That's secondary progressive. And less than 10% of patients present with this slowly worsening course from the beginning, primary progressive. These are all important things to keep in mind as we move forward through some of the slides, especially about treatment. If you've been to an MS talk, you've seen a slide that looks like this. This is adopted from the McGill University website. It shows you the different types. There's the relapsing remitting, where in between relapses, you go back to life as normal, no problem. Frequently, though, you're left with something. Even if it's mild, it's something that's unfair for you to have compared to the regular person. A little bit of blurred vision every once in a while after an episode of optic neuritis. So it leaves you with a little bit more disability every time you get a relapse. Hopefully, only a little bit. Sometimes it's more than that. And like I said, some of these patients will go on to slowly get worse over time. That's secondary progressive. And this is primary progressive, where you never see this kind of pattern of attacks. And I'm going to talk about what these attacks or relapses mean. So recently, the same panel of experts that met back in 1996 and came up with that definition met again in 2014, or 13, I forget. And then they decided that they wanted to update this a little bit. And I'm glad they did. We haven't adopted this into the clinical world as much as I wanted to. I use it in my practice every day, and I'll tell you why. And I'll tell you why it is important to keep these things in mind. So I told you very briefly that MS is a disease where there's inflammation, attacks of inflammation. This goes through the blood vessels into the brain, attacks. That's inflammation. In my mind, that equals activity. The new definition wants me to label whether or not the patient has activity. So inflammation equals activity equals relapses. And thankfully, they also said it equals MRI activity. So if I get your MRI today, compare it to one from last year, and there's something new, one new lesion, doesn't matter what it is, something is different from a year ago. Enhancing, non-enhancing, doesn't matter, that's disease activity. And I stress that because I'm going to talk about it in a little bit and tell you why it's important to label it as such. Progression equals degeneration. So unfortunately, although it's happening less because of all the efforts that we're putting into treating MS, over time, there's volume loss. The brain loses volume. Rapid aging. Sometimes I tell my patients it's like rapid aging. It doesn't happen at the same rate. It doesn't happen to everybody, so it's very difficult to predict, but that's slowly happening in the background, and that's what eventually leads to this slowly progressive type of MS. And there's no better way to capture it. Right now, the only way a doctor can tell you, or you can tell if you have progressive MS is you wait a year, and if you're worse than you were last year, or maybe 2 years, or maybe 3 years, that's when you can say, well, maybe I have progressive MS. It's never clear. It's always black and white. So with this new label of putting somebody as active or progressive, this patient here becomes relapsing MS with activity. These bumps are activity. Same thing here. This patient, right around this part, is maybe I can label them secondary progressive with activity. As soon as I put that label on, they took away secondary progressive with superimposed relapse, they took away the old definitions. As soon as I put on activity or relapses, I can treat with whatever I want, because they still have a relapsing component. So that's why it's key to document and capture that. And same thing, primary progressive patients can have just progression, but every once in a while, you do an MRI and you see a new lesion. Later, if I'm a physician treating that patient, I would label it as such. And then it's not only legal or insurance company, whatever, I feel like I am doing something by treating them with the medications that are approved for relapsing MS, because then I'm telling them that they may have a small relapsing component. So that opens the door to a whole slew of treatment options. We're going to do a small physiology lesson. Don't worry, nothing, it's in the evening, it's difficult for us to learn anything. But here's a nerve cell, very simple. So that's the cell body or the neuron. And then this is the fiber. This is the connection between this nerve and another nerve or the muscle. So this is the axon. And to protect the axon, as well as to make the signal travel faster, there's myelin. And it's basically the protective sheet around the cable, right? It's produced by these cells. They're called oligodendrocytes. They're sitting right there, and they're producing the myelin. And then the signal travels and jumps through the myelin wrapping, and that's why it travels much faster. In MS, what happens is the nerve cells leave the blood vessel. They go into the brain, and then they, either by secreting antibodies or directly, they go after both the oligodendrocytes, the cells that produce the myelin, as well as the myelin itself. It's destroyed. When the nerves lose that protection, they may eventually get damaged. Sometimes within an MS lesion, many of you have seen what an MS lesion looks like on MRI. There's some damage and there's some repair, so sometimes the myelin repairs itself. If there's enough of these cells surviving, they're going to do some repair. But sometimes there's damage. We lose not only the myelin, but we also lose the connection. And eventually, we may lose the actual nerve cell. And that's where that part leads more to the degeneration, the progression piece that we talked about. A very busy slide. Don't worry, we don't need to go through all of it, but I just wanted to highlight, this is what happens as the disease goes on. At first, it's mostly inflammation. It's mostly those attacks and new things showing up on MRI. Over time, and I wish I could tell you this, how long this time is, it is very different from one person to the other. You start to see less and less inflammation and more of this degeneration or progression. And there's almost a magical, not a magical, it's actually very difficult to define. There's a period where this becomes prominent, degeneration becomes prominent, you don't see as much inflammation. That's when somebody who is labeled as relapsing MS starts to show signs that they're secondary progressive. Again, this is all from untreated patients, from data from many, many years ago. I'm not talking about, hopefully with our drugs, we're not going to see this. I want to see this happen over here, when you're 90 or 100, or even maybe later. So our drugs are treating this, most of them right now. So they're lessening the likelihood of seeing lesions on MRI, lessening the likelihood of seeing relapses, and hopefully what we believe is that this inflammation drives down some of the degeneration. There are theories out there that they're independent. There's nothing that you're going to do about the first that's going to affect the latter. But from personal experience, as well as some anecdotal studies that have looked at patients, look back at patients, if you treat this, you're delaying this. And so, like I said, you're shifting this entire piece to later on. And maybe the brain doesn't shrink as much, there's less volume loss, and there's ultimately less disability. So we're going to focus our talk on these kind of following topics. Hopefully I was able to differentiate them for you a little bit. Firstly, we're going to talk about what do we know about reducing inflammation. I'm really not going to spend any time on the currently available treatment options. I'm going to stop and see if anybody has any pressing questions about them, because you know about them, you've attended talks about them, so we're going to just go over them and briefly talk about the groups that are available, and I'll take questions. Then I'm going to talk about what's coming. There's a couple that are coming. And then I'm going to talk about ways, when we see a patient who's just diagnosed, how can we tell how bad things are going to be for them? We're starting to figure that out, and I think that's very important, because not every patient is different. So if I can tell that patient that's going to be a little bit worse off from the beginning, I'm going to be more aggressive with them. And we'll talk about that. Then we're going to switch and talk about, all right, we've got inflammation cornered. We know how to shut it down. Almost. I wish it was 100%, but we know how to almost shut down inflammation. So what can we do about the other piece, the maddening piece, progression? We're going to talk about how we can slow it, or maybe even reverse it. A, through just reducing this. B, through protecting the nerves. So even if there's myelin damage, we're going to try and preserve the nerves. And then we're going to tell you about some of the agents that are there to reproduce the myelin. And then I'm going to tell you why I think we really need to focus on this area, and why we're probably doing a bad job measuring progression. I'm going to talk about new ways to treat or stop MS, and I'm going to talk about new novel ways to treat symptoms like cognitive problems and fatigue, and spasticity and pain. And if you're hearing the news recently, you'll know what I'm talking about this last bullet point. So, reducing inflammation. Looks familiar to anybody? This is the MS Society website. I actually pull this up when I'm talking to a patient. I go to this website. Pull it up, and I tell the patients, here are all the 13 available treatment options. Here's a kind of a zoomed in image. They're lumped in a really nice way. There's injectables, there's orals, and there's infusions. Going down with every patient, it's a different treatment algorithm. I start with all 13. I eliminate some based on what I know about the patient. They eliminate some based on about what they know, what they've read. And we slowly work our way down to a few options. We talk some more about it, and we get down to one option that they are going to try. So we have the interferons that are injections, as well as glatiramer acetate. We have 3 oral medications currently, and we have 3 infusions. Any questions about these? Okay, I'm gonna say a few more things about them. It's very difficult to compare unless it's been done in a trial where 2 of these drugs were compared head to head. It's really tough to compare a trial to some of these drugs that was done back in the 1990s or early 2000s with a trial that was just done a few years ago. So even if we're looking at a reduction in relapse rate and one looks double the other, that doesn't always translate into what's happening in reality. Things have changed about how we're recruiting into trials and everything else. So although I mention the numbers to my patients, I tell them, listen, it's very difficult to compare, and we don't know what's gonna work for you. Clearly, some of them may work a little bit better than others, either because they were compared to each other, or because anecdotally we kind of see that maybe the infusions work a little bit better. But with all of these drugs, there's a risk benefit. The stronger the drug, the more the risk. And that's a balance that we always have to talk about, and that's absolutely fine. But we will make the choice that best fits the patient. I wish I could tell you there's one algorithm, and now we have a few questions. Go ahead, sir, you asked a question, go ahead.
The 3 new injections, how often are they used?
The 3 new injections.
I'm not talking about having that beta serum.
Are you talking about the last 3 on the list, or?
No, it's
Okay.
the 3 newest ones.
I think I know which ones you're talking about.
Right.
If I go by timing, you're probably talking about, so Latimer acetate Copaxone used to be once a day, there's now a formulation that's 3 times a week. So it's the same drug, double the dose, 3 times a week. There is a generic version of it now called Glatopa, that's once a day, that's the only dose available. And then you're probably also talking about Plegridy, which is pegylated interferon, peg interferon, which is kind of like Avonex, but they added something to it so it stays in your system longer. It's under the skin. Avonex was in the muscle, this is under the skin, everything else is under the skin, and this is every 2 weeks. Yeah. Yes, sir.
Do you have patients that are on rituximab, and what's the prognosis for that versus ocrelizumab?
So we do have patients on rituximab, and a phase 2 study that looked at rituximab, not ocrelizumab, back in the day, I think Ann Cross out of WashU in St. Louis was the PI, showed really good results. I don't know the exact numbers because it may have been against placebo, whereas the trial for ocrelizumab was not against placebo, but it works. And currently, we do have some patients on rituximab for several reasons. Sometimes it's because we're not sure if this is MS or NMO. Sometimes the patient is an overlap. Sometimes it's clear cut. Sometimes it's not. Even if they don't have the NMO antibody, so we're now like shifting the ballpark. So when you're not sure, you might want to go with it, or when the patient has failed a few, you might want to go with it, and we see really good results. It's becoming much more difficult, though, to put anybody on rituximab. Insurance companies are just flat out denying. Sometimes a couple of letters of appeal, a few phone calls later, you can get them the drug. So I don't think anybody has looked at how it compares to ocrelizumab, because anecdotally you may not have enough numbers, but it works, and it works really well.
You had shown a slide up there, said that why do the activity attack the something? You showed how the MS activity attacks a certain part of the brain, and why do it attacks that certain part?
Why does it only attack a certain part of the brain? It's not a part of the brain, it's a type of cell. So this one,
Yeah.
so we don't know where it's going to hit. It can hit almost anywhere in the brain. It does prefer certain areas, at least that we can see on MRI, but it's attacking a certain type of cell. So it's attacking the nerve protection, but it can happen anywhere. So geographically and anatomically, when you're looking at the brain or spinal cord, we shouldn't forget about the spinal cord. It can happen anywhere. Yes, sir.
The medications that often patients start with one, not having success, go to another, and then another, and 3 or 4 until they hit the right one.
And hopefully, that's why spending time early on trying to figure out what their MS is going to be like, which is probably another $1 million question, helps, because then you can hopefully avoid some of them. When we didn't have as many options, frequently the scenario would have been maybe they go on injectables, they don't tolerate them or something like that. Now that they have options, they know that from the get-go, they can navigate the options a little bit better. But that's why knowing how the MS is going to look a few years down the line may make you want to be more aggressive, because you know they may not do well on a certain medication and you want to be a little bit more aggressive in your treatment. So the balance, the risk-benefit balance changes towards maybe let's take a little bit more risk because it's going to pay off down the line.
One further question, any combination where you take 2 of the medications?
Not intentionally. I just had a patient who did, unfortunately. She did not realize that she had to stop one. There were trials that looked at combinations of the injectables, and they didn't show any benefit from adding two compared to just one. And otherwise, especially with some of the newer agents, they're affecting the immune system in different ways, but it's probably not good to have a synergistic effect because you're probably going to increase the risk, and the payoff may not be worth it. Questions in the back? Yes?
Is it common that even after as much as 8 years of one of the injectables, that a patient will need to change medication?
I've seen it, I don't know if it's common or not, and it's a very interesting phenomenon. So what happens sometimes is, and that's another thing, maybe that patient's MS was always going to be benign or mild. I put it in quotation marks because I don't believe that any MS is really mild MS. Everybody's MS needs to be taken seriously. But that's a key question. Why all of a sudden, after many years, we don't know. Maybe something else, again, like triggered the immune system to go into overdrive again. And maybe then they need stronger therapy or a different therapy. Maybe they developed some tolerance to the medication that we don't know about. Some of these drugs we know have neutralizing antibodies that you can check. Sometimes we don't. And so, yeah, we see that, absolutely. Yes?
This is a question from someone who couldn't be here tonight. Is there any recommended cooling off time between treatments? So if you say started on Atomex and then, weren't able to use that, is there a recommended time period to wait before you start a new treatment?
It depends on what you're switching from and what you're switching to. A few of for example, we can use the oral medications maybe as an example. A couple of them at least can reduce a certain type of your white blood cell count. So you may not want to go to the agent number 2 until the count goes back up, and that duration can vary. Some of these drugs on the label it says when you come off it, you need to wait a certain period of time before you go on to the next thing. If you're talking about injectables, you can probably switch tomorrow. You stop one, tomorrow you switch to the next one. But when we move further down the list, it becomes a little bit more complicated. You go by label, you go by labs, and by how the patient is doing. Yes?
So you use comparative MRIs to see?
Yeah, absolutely.
Okay. So what is your recommended, if there is one, sequencing of MRIs in order to always be on top of where an MS patient is at any particular time?
Great question. So you may have heard when there's public awareness campaigns about stroke, time is brain. If you wait a few minutes, you lose more brain. Time is brain here too. We probably have a few months as opposed to a few minutes, but we tend to be aggressive. It depends on the patient, but if I had to generalize, time 0, you're starting the drug, I have an MRI. It could be within like a month of starting the treatment. I'm going to look at another one in 6 months, and almost everybody else does. If things at 6 months look great, we go to a year, unless they have problems. If things in 6 months look kind of like, maybe we're going to get this under control, another 6 months. Have we done it in 3 months? Yes. Have I done it in 1 month? Absolutely.
So a patient who has been taking, for example, let's just say Avonex to start with for more than 10 years, and then switches, let's just say, to Albaggio, and has not had an MRI in more than a decade, that's being deficient in the situation?
It really depends. I'm not sitting in that room, I don't know everything about them, so I
Okay.
can't tell you. But I would, advocate for getting an MRI when you're starting a new drug,
Okay.
just to see where things are.
Okay.
But then again, we don't treat the MRI, we treat the patients,
Yes.
right? So at the end of the day, maybe that's what the doctor has been thinking about. Any other questions? Yes? Absolutely not. That's especially if you do the killed virus, the shot and not the mist. That's been proven to be very safe. Because it's a killed virus, it's not going to increase your risk of infection in any way. Some of these drugs may make your response to it less than optimal. It's still worth to take it because even if it doesn't protect you 100%, it's still worth it. Especially since getting the flu may be a problem. Yes?
I am using Avonex, but at the beginning of
Mhm.
you know? And then funding came in, so I continued on Avanex. Should I have gone with Avagio? I mean,
You know what the number one thing I hear from my patients who are on medication that's working for them? Don't rock the boat.
okay.
Are we right in saying that? We don't know. Well, if we can make two of you, we can put one on Avagio and one on Avanex, and go 20 years into the future and see, then we'll have an answer. But other than that, no, I would say if you're feeling fine and you're doing fine and things are looking okay, then I wouldn't necessarily switch.
Okay. Thank you.
Sure. All right. Move on? Okay, so let's talk about some of the new, potentially exciting stuff that's gonna be happening. Ocrelizumab. There was a question earlier about rituximab. So ocrelizumab works almost the exact same way as rituximab does. It's attacking a certain type of white blood cells, the B lymphocytes, and it's killing them. So it's wiping them off completely. They're gone. They stay gone sometimes for up to 6 months. That's why the drug's probably going to be approved for infusions that are given every 6 months. They recently announced results from phase 3 trials. So phase 1 is when you're looking for safety. Phase 2 is when you're looking at a smaller number of patients, looking at safety and seeing if it's worth it to do a big study. Phase 3 is what gets you approved by the FDA. So they did phase 3 trials, and they showed that it reduced the relapse rate, which is our number one outcome. How many relapses do you have per year, compared to Rebif, or interferon beta 1A sub-Q, by 47%. Okay? This is not the first drug that was compared to an active drug. In the old days, we used to compare it to placebo. Alentizumab, which is one of the infusions that we briefly mentioned on the other slide, was also compared to an active drug. The most common adverse events in the trial were infusion-related reactions. We hope that it's going to have a safety profile similar to rituximab. Now, this is an immunosuppressant, just like a lot of the drugs on that list. Immunosuppressant means there's going to be some increased risk of infections, and the infections can vary. There are infections that, I'm not talking about the common cold, I'm talking about infections that most of us won't get if we're not on this medication. But again, it's a balance. I would take this medication, not just any medication if needed, in a heartbeat if I thought it was going to benefit and protect my brain, right? But I'm just kind of telling you about the different things that come with it. Of course, we don't know. Once many people take it after the trials, that's when we'll know exactly everything about it, just like some of the other drugs that are on the market. It's only after a lot of people take it is when we know. Yes, sir.
I'm aware of at least 3 of the drugs that have developed PML. Are we looking at it?
So yes, so I didn't talk about PML today for the sake of, but I'm happy to answer that question. So if we go back just real quick, we're not going to spend a lot of time on this.
What's PML?
PML is progressive multifocal leukoencephalopathy. It's a very rare infection, so it's easier to call it PML. It's a virus, it's called the JC virus, that half of us are exposed to. But the infection it causes, we don't even feel it. And it stays dormant in our body. And then when our immune system is compromised, the biggest thing was AIDS. So we started seeing a lot of those cases back in the 80s when patients started getting AIDS, when people started getting AIDS. It can cause a brain infection. It used to be fatal, underlying used to, because mostly with PML that's developing with these drugs, 80% of patients survive, but you may end up with more disability than you went in. So it's still a rare infection. Out of these, and MS experts never in their lifetime thought that they were going to be that much of experts in PML, but unfortunately, patients on adalimumab have a risk to develop PML. There's risk factors. There's 3 things that if we know about you, we can kind of estimate where your risk is going to fall. So if you have none of the risk factors, your risk is really, really low. Even if you have all 3, your risk is high, but it's not, again, it's a risk benefit. Some of the oral agents have a few cases of PML. Fingolimod and dimethyl fumarate have 3 to 4 cases. Maybe one of them has 5, but semantics, we don't, it's a few. It's 3 or 4 out of 50 to 100,000 patients that are taken. So they're still fairly new. We don't know what's coming, but it's probably looking back, the risk is probably going to be small, less though, and we don't know of risk factors like we do with vedolizumab, but it's there. Now, ocrelizumab, there are cases of PML on its parent, rituximab. So are we gonna see some? Potentially. It's still gonna be probably very rare. And I think I was reading a paper recently, I think this was very interesting. They said, just to put it in perspective, the risk on most of these drugs is less than the risk of dying in a car accident. So, if you think about it, we get into our cars every single day, and we go on highways, especially in this area, where you might be very prone to accident. You don't think about it twice. You need to get from point A to point B, and you don't think about a car accident. So why is this stopping you when we're talking about the brain? I'm not saying everybody should drop the injectables and go on these drugs, but I'm saying that the risk is worth taking. Does that answer your questions? Okay. You had another question or something here? Okay. Another drug that's coming down the pipeline, niclizumab, that's another antibody. It's not an infusion, it's actually an injection. And it also has shown good benefit in reducing relapses compared to placebo. So far, no safety issues associated with this drug. So we'll be up to at least 15 options in the very near future. Questions? Yes?
You had mentioned that rituximab has been effective in your
Mhm.
practice, but the insurance companies are way adverse to providing
Yep.
approval for it. Why would that be if there's?
Because it's not FDA approved. That's the simple. So
It's not FDA approved for MS.
for MS. So then they could say, why don't you try the other FDA approved? So most frequently on the first one, it's going to be denied. And it's going to take a lot of work. Fortunately, we have a pharmacist on staff, so we work together. It's going to take a lot of work and coordinated efforts of convincing them that in this individual case, it's warranted. Fortunately, that's going to only be an issue for the next 6 months or so. I'm hoping if ocrelizumab becomes approved, and that would be our option. There is a clinical trial for ocrelizumab that's continuing. So now it's done. The trials that are ready for submission to the FDA, that's all done. But they've continued the trial where everybody's getting it. They're kind of post-marketing type of trial. So hopefully, if patients can get in that, then you can also get the drug. So there's different workarounds. Yes.
So both of those drugs that you just mentioned are mainly showing evidence of reducing relapsing
Mm-hmm.
situations, not helpful for progression.
We're going to talk about it in a couple of slides. We're going to mention what's been shown for progression. Absolutely. They are targeting the immune system, so they're going to reduce inflammation. So the first thing I would look at is relapses. But then, the conversation that I mentioned earlier is I'm a believer that if you control inflammation very well, very early on, you're going to prevent progression. If you're in a room and you already have progressive MS, that's too late. You're going to look at me and say, so what? That's not going to benefit me. Fortunately, we have a lot of things that we're going to talk about that may help progression. Yes?
In the early work on this,
Okay, wasn't that?
Yeah, there was some negative results with lupus and rheumatoid arthritis. What have we learned now?
What was the question?
There was some negative effects with lupus and rheumatoid arthritis.
It's very interesting I haven't looked into the literature to look into that question. So rituximab, the parent drug, works not just it's not approved for MS, but it works in diseases like lupus, rheumatoid arthritis. When they tried to test this drug, because it was a newer version of some of those diseases, they stopped the trials because it wasn't as effective. I find that very interesting. They only slightly adjusted the molecule. So what's going on behind the scenes? I don't know if there's literature about what's the difference, to be honest with you, but I find it very interesting that there's that contrast.
It was due to using mouse DNA as opposed to a completely humanoid version.
You would think that if you use a humanoid version, it would work best, overall. It doesn't matter what disease it is. So it may have been the way the trial was designed. Maybe it's easier to get outcomes, reduce relapse rates for MS patients than it is for those other diseases, how you measure outcomes. So it could be something about the design and not about how the drug works.
It was the exact same active ingredient?
No, they switch it like you said, so instead of using mouse DNA, they use human DNA, so it's more a humanized version. And then I believe if you look at the molecule, there's a few different things about the molecule itself. But it goes after the exact same receptor, the CD20 on the cells. So early on I talked about how can we, when we're meeting somebody for the first time, you're getting to know your MS for the first time, how can we tell if things are going to be better? We basically attempted to design write a grant and say, call it crystal ball. Because that's basically what it is sometimes. You're looking into a crystal ball. So we know a few things, and I listed them in almost separate categories. Things that we can control, and things that we may not be able to control, but they may give us an answer. The first three are, very briefly, we know that low vitamin D is associated with more inflammation, and so we tell our patients, go on a vitamin D. We want your level to be somewhere in the middle. The range in most labs is 20 to 100. We want you in the 40s or 50s. We don't want to go crazy and overboard, but we want you, because believe it or not, most of us are very low on vitamin D. Because even finally there's warm weather, even in warm weather when there's sunshine, we're putting on sunscreen. And that's how our body makes vitamin D, is from extra sun rays. So when we're putting on sunscreen, we're not making enough vitamin D. Smoking, many studies have now shown that smoking makes MS worse. More relapses, more inflammation. So that's a hypothetically easy reversible risk factor. And lastly, there's been a few suggested studies in lab rats, as well as in epidemiological studies in human, that high salt intake can make MS worse. So things that I can tell my patients to do right off the bat. Next are things about your MS. So I look at the type of the symptom, where it hit, what were the symptoms like. If after the first attack you are coming in and you're telling me, I don't think my thinking is right, it may be very subtle, but you have a problem. Of course, if you don't have an abnormal MRI, that's a different conversation, but how abnormal is the MRI? What's going on? Is there some atrophy already on the MRI? Black holes is the term that you frequently use. You hear the doctors use, when there's a lesion that leaves a quote black hole, that usually means, not always, that there's permanent damage in that lesion. So all those things tell us that things are pretty aggressive. Sometimes the doctors will do a spinal tap, and if the spinal fluid is abnormal, I wish I could give you a number. I wish I could tell you, put all this in a computer and it tells us this is how things are going to be. It's more of a kind of a gut feeling. Your doctor looks at everything about your story and gets a feeling of where things are going to go. Sometimes by the time you've come to the doctor, you've already had a couple of relapses in a few months. That can tell me that maybe things are going to be a little bit more aggressive in this patient. We are looking at ways. I think this is going to be very interesting work. The manuscript for this project is almost done. We're going to submit it very soon. It was done by one of my collaborators, he's a biostatistician, works in MRI, where you look at new lesions. They did this mostly in early patients, but it doesn't matter. Any new lesion that developed, they put it in a regression model, so in a big statistical model. They put everything we know about the patient, and it predicts if that lesion is going to recover or not a year from now. So that's great. So if your MRI has many lesions that look like they're not going to recover, I may say, you know what, I want to shut this down, I'm going to be more aggressive. Still in its infancy as far as where we're going with this, but this has a lot of potential where, your MRI would come back, you don't have to do anything, the MRI would come back and I would see either red dots or green dots saying this is going to likely recover, this is not going to recover, and we would build this into what we know about your MS. Same thing is, all the lesions look alike, right? We don't know what's going on within a lesion. Once it's there, we don't know what's going on. Well, we kind of do. We can look at how intense, how bright is it. There's been some suggestion that the brightness may indicate how much recovery has happened within the lesion. And what we're looking at, one of our residents is actually doing his research project on this, is seeing on a couple of the treatment options, before and after, did it change how bright the lesion is, and did that tell us anything about the patient's illness? So again, very early in its infancy as far as studies, but something really we're excited to do. Yes, sir.
In the MRI, how does MS appear?
I wish I included slides. I took them out last minute. But so it's
No, but you say you take an MRI and then later you take another MRI.
Yeah. So basically, what you're looking for are white matter lesions. You look at normal, healthy looking brain tissue, and there are certain parts of the brain, you can see white spots. They're usually ovoid shaped. This is bigger than a typical lesion. They're about 5 millimeters in size, ovoid shaped. They look bright white. If the patient gets contrast and the lesion's inflamed at the time that we took the MRI, it'll also pick up contrast, so it'll look inflamed. And then sometimes, after a while, it can, on a different sequence, because you're in there for 20, 30 minutes because we're getting several sequences, it will look dark. So it will change appearance a little bit. On a different sequence, it will look dark. That brightness never goes away. So you accumulate more over time, or it rarely goes away. So on year 1, I get an MRI, I see hypothetically 10 lesions. A year later, I see 15, and I can tell which ones are new. So I say, you've had 5 new lesions. That means something. That means activity, like I said. So that year, even though you're feeling great, your MRI showed that you have some activity. You're 10 times more likely to get MRI activity than you are to get a clinical symptom. Yes?
Could you basically give the opposite of that? Like, if you had 10 lesions and then 6 months later you still have 10 lesions, but you're kind of in worse shape? That's what happened.
So it could be you're in worse shape because you're just not feeling great. All of us go through times in our life where we're not feeling great, right? You are at a disadvantage because you have MS. So a person that doesn't have MS may go through a period where they're not feeling great. So, or it could be that this is the other piece, like the slowly worsening kind of piece, but 6 months is too early. So I wouldn't say, that that's what it is. I would wait a year or 2 years even before I call it that. Because it may just be a temporary thing. Yes?
How does all the acid help with MS?
Not directly. Indirectly, you need to make sure that all your vitamins and nutrients are up to date because you don't want another disadvantage affecting your brain and spinal cord. As far as I know, it's not linked to making us worse or better. We're getting low folic acid right now. But I would say it's one of the things we look at. It can cause nervous system problems. So we want to make sure it's not because of a low vitamin, an easy fix. And then we want to make sure that you maintain a good nutrition, maintain all your vitamins, so that you're not having another reason to feel worse. Other questions? Yes.
Do you think stress is a factor that may bring on cause events or trigger the habit?
It cause MS? Probably not. You will hear people say that they had their first attack after stress. You will hear some people say they had their first attack after a vaccine, and they will claim the vaccine, right? Probably you were always going to get it, and something had to trigger it. Stress can certainly make the immune system go into overdrive, and maybe that's why you notice a symptom. It's been shown. I don't think it's been clear-cut proven because how do you really measure stress in a study, right? I mean, you can ask. It's a subjective thing to a certain degree, but same thing with a vaccine. It just made the immune system go into overdrive, and you have the first symptom. It may make you feel worse, absolutely, and it may trigger a relapse, but hopefully that's all that it does. All right. So, talk about how can we predict worse MS later on. Let's talk about progression. If everybody's ready to move on. First, we're going to talk about slowing progressions through just reducing inflammation, because like I said, one probably drives the other. So, a big question. If you have progressive MS, should you go on any of those treatment options that are approved for relapsing MS? Or should you stay on them if you're already on one and now you're feeling or your doctor is telling you this looks like progressive MS? Well, not an easy question to answer, very individual answer, but this is why I stress that activity piece. If there is disease activity, I am treating. It doesn't matter. You can go to 10 different specialists and you get a different answer, but I think this is a justified answer based on evidence. If there is activity, I'm labeling this as progressive MS with a relapsing component, and I'm putting you on treatment. And what do I mean by activity? Either a new symptom that sounded like a relapse or something new on your MRI. The thing is, this transition I showed you, it's a block, it's not a line. You don't wake up one day and you're progressive. And though it can take 1 or 2 years before your doctor's even sure that this is progressive. And so, in that period, I'm not giving up on you. I'm treating. And then we'll see what happens. I'm still labeling this as relapsing MS until I'm absolutely sure that it's maybe not. in some patients with secondary progressive MS, when you stop the drug, they have a relapse. So they were, maybe their inflammation was controlled, and when you stop the drug, they go back and have a relapse. You go back on the drug. So absolutely, you see how it's a different scenario for every patient. The risk-benefit conversation may be different. I may want to think less risk because I'm not 100% sure that the benefit is going to be that great. Very individual as well. And lastly, and this is where we're going, there are going to be medications that are going to be approved for the treatment of progressive MS. So it's going to make our conversation much easier. Let's go back to ocrelizumab. So we showed that it reduced relapses, was the first drug to show positive results in primary progressive MS. And because of that, and because there's no treatment options approved for primary progressive MS, it has been granted breakthrough therapy designation by the FDA, which means it gets a faster review process. Typically that can take a year by the FDA to be on the market for progressive MS patients. They showed in their trials that the rate of disability of how the MS got slowly worse was reduced in patients treated with ocrelizumab compared to placebo. Again, this is for primary progressive MS. And it also showed that it likely promotes a reduction in accelerated aging, brain atrophy or volume loss. Another agent that has gotten some interest recently, ibudilast. So this is actually an agent that's been used in Japan for over 20 years. Not for MS though. It's actually, it goes into the brain, it can cross the blood-brain barrier. Not a lot of drugs, most of the drugs work out on the outside of the brain. This one can go in, and it's been suggested to have an effect on the immune system as well as potentially a neuroprotective, so it can protect the nerve cells. Like I said, but it's been used in the past because of different mechanisms to treat drug addiction and pain, but it was also studied in MS. And it showed a reduction in disability progression in brain atrophy. So not the effect on the relapses, but the effect on the slow worsening piece. And that's why it's currently in a phase 2 trial, so the smaller trial involving patients is still going to need to go through a different process, but it was also designated, a slightly different designation by the FDA. Some of these are confusing. Fast track designation, which means it's going to get a quicker process through development and review. So we may see it soon, or rather soon.
So is that because it's already used as something?
No, it's because it's for a problem that we don't have an answer to, progressive MS. So that's what the FDA cares about the most. Yes?
Like how long would that market?
So for ocrelizumab, I'm hoping before the end of the year. That's what we are hearing. For this drug, I would say, the thing is, it depends on where they are in their phase 2, maybe 1 or 2 years, potentially. I could be way off on that. Either I'm overestimating or way underestimating. Yes?
You know, it seems over the years that I have noticed that drugs that are used in Europe for 20 or 30 years and they're used in Japan for 20 or 30 years, and that's before they even go into testing in the US. Now, I would find it difficult to believe that all of Europe, especially countries like Germany and France and you know, Japan, who are such innovators in so many ways, would be using something for 20 or 30 years that doesn't work, and with all due respect to our FDA, FDA, I'm saying to myself, what is it that keeps us from putting these things into trials 15 years ago?
Actually, some of it is money, so maybe there wasn't a pharmaceutical company behind it, because you really need a lot of money to do the trial. And unfortunately, I wish the FDA accepted trials or things that were approved elsewhere. It doesn't. And the same goes the opposite way. We don't see it as I'm sure people are sitting in Europe now saying, I wish I was in the US because they have this and this and this, and we don't. For example, this drug, it wasn't even a conversation about MS. Not at all, until recently, within the last few years. It was used to treat something completely different, and then somehow, I don't know the background story that well, they found out that, hey, it could help. I think the fact that it can cross into the brain made them look at MS to see, well, is it going to affect the immune response? And it did, but it affected the different type. I don't think they were thinking about progressive MS. But lo and behold, it's actually working better for progressive MS. Yes,
When you say brain atrophy, which is a really scary term,
it is.
see my brain's actually getting smaller.
Yes, but at a very, very slow pace.
I don't feel like I feel like smart, like I'm concerned I'm fairly intelligent, is my like,
So it's not just the brain, unfortunately, and I see that you're in the chair, so it could also be the spinal cord. And it is, there's some volume loss, but it's very slow. It's faster than normal aging, but it's slow. It's not like, and that's why when I talk about how we better capture progression, if it was fast enough, then I'd get an MRI a year later and I'd be like, oh, there's a difference, we're good. It takes years. And some people, you see it more in the brain, and those people may come into the office and say, my memory and thinking is bad. And some people, you may see it a little bit more in the motor area, in the spinal cord, and they may come in and say, my walking is worse. So that's why everybody's different. Questions? All right, moving on. In another agent, siponimod, if you're familiar with fingolimod or gilenya, this is kind of the same family of agents. It works through the same receptors. It is more specific, more selective. So it goes after only a certain type. These receptors are widespread in the body. This goes after only a few types of them. Basically works by reducing the number of circulating lymphocytes, one of your white blood cell counts, and they cross to the brain less often. And it did show some efficacy in relapsing MS, just like fingolimod did. It's currently being studied in a phase 3 trial, so the larger trial for secondary progressive MS, is because there's also the potential that it could have some neuroprotection. T-cell now. This is a novel T-cell vaccine, and it's currently being studied for secondary progressive MS. So what happens is they take the patient's own T-cells, and they modify them, and then they re-inject them into the same patient. So it's your T-cells. They just now go after the bad T-cells. So they take your own white blood cells and they train them to go after the bad ones. In theory, it works really well. We're going to see how it works clinically. It is being studied in secondary progressive MS. It's going to tell those bad T-cells, stay away from the brain. Maybe we can flatten that line. Instead of it being a slowly worsening line, maybe we can make it a flat line.
So, excuse me, when you say a vaccine, that is
It's-
something that sounds like it's before.
It's a misnomer. I don't think it's really a vaccine, but the idea that it's actually going after, it's retraining the immune system. Unfortunately, that's, if you look it up, that's how it's called, and even in the trial, yeah, but it's a little bit of a misnomer, absolutely.
Any trial?
This one I know, I think they're closed to enrollment, currently, but that's very, you can go to clinicaltrials.gov, you can go to the MS Society website where they list all the research studies. And then the thing is, it's a little bit of a homework, and hopefully the MS Society can help with this, if knowing what center is enrolling. Because for example, we were a center for T-cell. We had 3 patients total, I think, in the trial, and they all had to leave for different reasons. But, and the hospital next door may not. So if you're, you may have no reason to leave your neurologist and go see somebody else, but if you know that this hospital is recruiting, you can at least call a phone number and see if you qualify just over the phone.
Did any of those 3 have to leave for adverse effects?
Not related to the trial.
Not really. Could a drug like this actually, looks like it could reverse the effects of MS?
Well, interesting question. If it's training the T cells, it may stop. So there's a difference between stopping and reversing.
Yeah, I
And
know.
that's what we're going to talk about later. So it may, potentially, it may stop it, right? But you're going to have to keep giving it so that you keep killing only the bad T cells that are going to cause the autoimmune reaction. So it may stop it. And that's what all the drugs aim to do, is stop this thing, stop the inflammation. Absolutely. This may stop the inflammation in a different way, so it's affecting progression more. I think we don't understand as well, but yeah. So, talked about reducing inflammation, let's talk about neuroprotection. So remember I showed you that nice picture, myelin is gone, the nerves are exposed and vulnerable, and now we're going to try and protect them. We're going to see what can we do to make sure that even though they've lost their protective covering, they're not going to die off on us. And there are several things that are going on in that arena. So there's a lot of talk, I didn't include it in the slides, about inflammation causing oxidative stress or oxidation. And that this increased oxygen, not the good oxygen that we breathe, but we call them reactive oxygen species, they can cause damage through different ways, because we're working through the energy centers in the cells called the mitochondria, damaging those, different things. So one really cool way to deal with this would be to give agents that stop this oxidative stress. Vitamin E is a big antioxidant. You all hear about vitamin E. You know, I think they all have an effect, but the effect is so minuscule, things like vitamin E, that you may not feel it. You take it, you may be working, but you may not really feel it because the effect overall is not that big. But this is one drug that's used to treat other neurologic diseases where oxidative stress is known to work. These are diseases that originate in the mitochondria. So the metabolism site in the cell, diseases that often appear in childhood and affect kids. And it is now being studied in another phase 2 trial for primary progressive MS. So we're going to see if we stop oxidative stress or reduce it, can we slow down the slowly worsening process. Phenytoin, if you have seizures or know anybody who has seizures, it's called Dilantin is the trade name. It's an anti-seizure medication. What is it doing here? Well, seizures are basically overactivity of some brain cells. Sodium goes in and out and things happen at a faster rate. Most anti-seizure meds kind of slow this down. They turn down the electricity by slowing down how things like sodium and potassium go in and out of cells. We find that when we block this or slow it down, that affects the process by which the nerve can degenerate or worsen. It's a drug that's readily available, it's cheap, we know everything about it because it's very old. And I only included one anti-seizure medication. There's several anti-seizure medications, as well as some heart medications, because they also work on electrolytes that are being studied to try and protect the nerve cells when inflammation is happening. So let's try and make the environment a little bit less injurious to the nerve cells. And it was found to have a protective effect on the retina. I'm going to talk about how this was measured in a little bit. In patients who had optic neuritis, inflammation of the optic nerve, if you give it within 2 weeks, or you have to give it early enough during inflammation to protect the nerves from getting damaged. Make sense? Questions? Yes.
Is there something about sodium? Because I saw an earlier slide about possible
Sodium,
trigger.
no.
One was like high sodium.
Yeah, high sodium.
Sodium.
Not the same conversation. This is more about on a microscopic level. Absolutely. You are very right in that question. Any questions about this? Biotin is a vitamin B, is one of the vitamin Bs. Not at the doses that you can find over the counter, but at much higher doses, it has been shown to potentially have a disease impact on progression, on slowing the slope. They are studying it in bigger trials, and it also showed improvement in disability outcomes. It is available. Unfortunately, it is not approved by many insurance companies. I forget, my pharmacist told me how much it costs per month. So you may have to pay for it out of pocket. It's relatively safe to do, and it's a vitamin, right? But it's one of those vitamins that at a higher dose may have a different potential. Who knows simvastatin? It's a cholesterol medication. I'm going to raise my hand in the very near future when I go on one of these drugs. So you hear about statins in a lot of things. They affect, not only they reduce cholesterol, but they also have kind of a direct effect on inflammation. You've heard about studies in Alzheimer's disease and other neurologic disorders. Well, it's also been shown to work in MS. Again, in the different form of MS that you think, so it's maybe driven by inflammation, but in a different kind, in secondary progressive MS. And maybe it's reducing brain atrophy. Smaller studies, the reason I use the word maybe is because all of these are fairly smaller studies, so we need to confirm them in a large number of patients before we say for sure definitely. So why do some of these drugs, they work on inflammation, but they're working on progressive MS and not the relapsing kind? Maybe because they're working behind the scenes. So what happens is, in a typical MS relapse, the blood vessels allow the white blood cells to go in. We call it breakdown of the blood-brain barrier. That's when you see contrast enhancement on MRI. In progressive MS, it's been shown on biopsy or autopsy that there's inflammation going on behind it. So drugs can't go in, white blood cells are not going in. It's something that's going on within the brain. And so that's maybe why the drugs that we use for the most part to treat inflammation may not work as well. But maybe some other drugs are making their way in there. Like simvastatin, like I showed. This guy, maybe they're working because they can go into the brain and they can work on the inflammation inside the brain. And that's just a theory. Yes?
When you say simvastatin, are you referring to all statins like Crestor?
You would think that all the statins should work, but I think simvastatin is the only one that's been studied, at least that's as far as I know. But you would think they would all have the same effect. Now, it could be something about simvastatin that's about that specific molecule and not about how statins work in general. And I don't believe that that's been looked into. Okay? So we talked about reducing inflammation, we talked about protection. We couldn't do neither, so now let's try and repair that myelin. It's been lost because of the direct hit against it. I told you that the body itself can repair some of the myelin. When I'm looking at a lesion on MRI, at least early on, I can't tell how much of it is going to repair and how much of it is not. But if I can give you a drug that's going to try and tell those cells that produce the myelin to kick in and work a little bit harder, maybe we can promote repair. It's not going to be a perfect, it's like, I always liken this to, your brain is a really big highway, and it has potholes. Those are the MS lesions. What we may be doing with this is fixing those potholes. It may not be perfect, and you know potholes that have been fixed that are still not perfect, but it's better because it at least allows traffic to go by, right? So that's maybe what we're dealing with some of these drugs. So far, there's several that are being studied. Same thing, it's not like miraculous breaking news for any of them, but it is very encouraging. I want to first mention a fairly novel technology that was developed by Dr. Jonah Chan. I know him because I met him at several of the MS Society Fellows conferences. Through work funded by the MS Society, he developed a way, he didn't look at drugs or anything. He just developed a way where we can test thousands, hundreds, if not thousands of drugs to see which would promote this, which would make those cells kick into overdrive very quickly. Instead of spending hours or years in the lab trying to figure that out, they were able to do it very quickly. I'm not sure if we saw a video at one of the conferences. I'm not even sure if it's available on the MS Society website, but it's cool to just go in and see how this thing works. Because of this, the result is that what they did is they took a lot of the drugs that are already available, both over the counter as well as prescription drugs, and they tried them. They just threw them in there and they saw what would potentially promote repair. And many showed some benefit, and some of them they took it to the next stage. They tested it in the lab, and then they tested it in patients. This is one such agent, clonazepam. It's an antihistamine. It's an allergy medication that is available over the counter. Now, don't all go home and start taking this drug. I think that one of the side effects is drowsiness. So I don't want you to, if we have a mass transit problem tomorrow, we'll know why. So it was one of the agents identified through this method, and it showed promise in improving conduction along the optic nerve after an episode of optic neuritis. In those patients that have had optic neuritis, some of you may have had something called visual evoked potential. It's not enough time to go into what it is, but it measures conduction along this piece of the visual system, the optic nerve. And probably through promoting myelin. So remember how I told you it makes things go faster? Maybe through myelin repair, things went faster here, and they were able to see it on those studies. And the studies are still in their infancy. They're actually going to talk about these results during the American Academy of Neurology meeting that's happening right now in Vancouver. And we're going to know more about the numbers, what the numbers look like. But I think this is going to be very exciting, both this technology as well as some of the agents that are going to come out. And this would be something you would go on and you would stay on. It would be relatively safe, so it's not potentially affecting the immune system, but it's promoting repair.
But is this strictly for the optic nerve?
They did it in the optic nerve because it was easier to measure there to begin with. You would hope that it would work everywhere else.
Okay.
The optic nerve may be a little bit different than the rest of the brain, but I think that it's going to work on different parts of the brain. Maybe I'm being optimistic. We'll see. A few other agents that have been studied have shown myelin repair, at least promoted. This is a monoclonal antibody. was shown to promote myelin repair in some lab studies, and it's now being studied just for safety. So we want to make sure that humans can take this safely, because it's been just studied in lab animals. A hormone-like substance, these results are also being announced in the AAN, in the American Academy meeting going on right now in Vancouver. A hormone-like agent that has positive results in myelin repair in animal studies. The investigators said, I was able to look at their poster online today actually, and it basically, they said very safe, we'll see. And they're gonna advance it to test it in patients very soon as well. You may have heard of anti-LINGO antibodies. These went through a trial, optic neuritis again, so the optic nerve. They announced their results a year ago, in a meeting a year ago, and they showed the same thing, they improved signaling along the optic nerve. They're studying it for relapsing and progressive MS as well. So repair is coming. A lot of this is going to be down the pipeline, hopefully in a few years. Nothing is readily available right now, unless you go home and buy that antihistamine.
So these are all chemical-based trials, right?
Mhm.
What about immune therapy potential? In other words, for substances, elements of your own body, which is so effective now,
so
we're
let-
finding with cancer.
Exactly. So, and that's where kind of things like Desalna, that's where it came from. The idea of
Right,
that,
right.
because you're taking your own immune system and you're training it against the immune system. The thing in cancer is you can train the immune system against the cancer cells. The problem here is the immune system itself. So you got to train the immune system to work against. It's a little bit trickier, but they're doing it. This is not the only vaccine study, quote unquote. But yeah, absolutely, that's a great question. There's one more thing that we can do to modify the immune system that's coming towards the end of the talk. So, I keep saying maybe and slowing progression. And I'm not sure if you're noticing that I'm not too excited about when we say slowing progression. And many of you in the room are going to understand what I'm talking about in a few minutes. This is how we measure disability in our MS trials. It's called the Expanded Disability Status Scale. It was developed by Dr. Kurtzky, who worked, I forgot where, at the VA for many years. He developed this. It's a great tool it's based on a neurologic exam. It's a great tool to measure disability in MS patients. It included everything that they thought was important back in the 1960s, and then later when they modified it in the 1980s for MS patients. But it does not capture everything. So it's a 0 to 10 scale. The first part of it is you're still walking, but your walking here starts getting affected. When you hit 6, you're using at least a cane to walk. And then you go up. When you're using a walker, you may be a 6 or 6.5. When you're using a chair, you're a 7, and so on and so forth. So why is this deficient? And there's one big flaw that's limiting a lot of our trials. Show of hands, if you're using a cane or a walker, even though you're taking your medications, you ever feel like you can throw that cane away, even if you're feeling 100% better with your vision, or if you're feeling 100% better with your bladder, or if you're feeling 100% better with your cognition? No. If you're in a chair, you're going to be a 7, even if you win a Nobel Prize because your brain is functioning great. So it doesn't weigh things equally. That's my problem. As soon as you stop using a cane, you're stuck at a 6. And you may come back and tell me, doctor, I was able to do the MS walk using my cane and I felt great, but I needed something for stability. You're still a 6. Even though maybe a year ago you were barely able to make it to the bathroom. I'm exaggerating just to make a point. So that's one big area. So now when we say things, they slow progression, well, if you enter a trial at a 6, even if you feel 100% better, you leave the trial at a 6, you're going to be one of the negative results, but you may feel like $1 million, potentially. And I also said that it doesn't capture everything. So it really does a good job for measuring physical disability and gait. It does an okay job measuring cognition. It does a poor job measuring vision because it has a regular vision chart, but it's not the type that actually impacts your quality of life on a day-to-day basis. It's a lower contrast vision. We don't have time to go into that today. And it does a really poor job measuring fatigue. Raise your hands, how many of you have fatigue? There we go. So it does a really poor job measuring fatigue, because this is a subjective symptom. So we are trying to develop ways to go around this. Raise of hands, how many of you are wearing something like this? A Fitbit or something similar? I was hoping more of you would be. So this is great. If you wear this, if you go home, you can look and say, oh my God, between the hours of 2 and 4, I didn't move at all. Or oh my God, Wednesday was a really bad day for me. That's why I move around when I give talks, because I get extra bonus step. But has it been studied in MS? Well, yes, it actually has been shown. Output on some of these. Some of them are actually waist-worn, not wrist-worn like the Fitbit or others. They are associated with the disability levels. They're associated with MRI outcomes, and it has been shown that MS patients over time, they do less well on these things. So instead of just measuring how much you can walk when you come in for a trial visit, why not have you go home on one of these? And in other diseases, not yet done in MS, it's been shown to capture fatigue. If your pattern changes, if you're very active at 8 a.m., but then by 4 p.m., nothing, and it's a consistent pattern, that's physical fatigue at the end of the day. So it can also probably measure fatigue really well. And I think it has great potential to capture those subjective symptoms like fatigue. We will make it objective. We did put in a grant. Unfortunately, they thought it was very over-optimistic in what we wanted to accomplish, so we're going to divide it into smaller grants and try again, because it's really worth testing. Yes?
I just finished a walking exercise study where I
Sounds nice.
for the Case Western Research in Ohio.
Mm-hmm.
I just turned in all my data, and she said if I'm interested to find out what the data looks like, that I can check in with them. But that's exactly what we did. I wore this pedometer, and and they gave me like this 14-page paper that I had to fill out, about what I did during the day.
Yeah.
If I was tired, if I hurt myself, and did it affect did it affect anything throughout my entire day?
What I propose to do is, we would automatically train this to, you would have an app on your phone, and if you looked less active, or if you had a pattern, it would pop up and ask you, are you doing okay? Rate your fatigue right now. And then same thing with cognition. You test your cognition when you go into the office. If you're doing a trial, this would pop up on your screen and would ask you questions like throughout the day, not every day, so that we're testing your cognition at different times during the day. In addition to everything we mentioned, just one more piece of ways to monitor MS patients. So we talked about MRI and clinical. I want to briefly mention OCT. This is one of my areas of research. So optical coherence tomography. You go into the office, you sit in front of a machine, you look at a red dot, in 10 or 20 seconds, less than a minute, it scans your eye. And it tells you how thick your retina is, the back part of the eye. Back part of the eye has nerve cells and nerve fibers. And they are thinner in patients who have MS compared to an average person off the street. But what we've shown, what groups out of Hopkins have shown, that it correlates with MRI. So you lose brain volume, you will lose retina. Not at kind of a rate that goes hand in hand, but this is quicker to see and much easier to see. So we've shown that in patients that we followed over an average of 5 years, those that did really well, that qualified as no activity because they had no MRI changes, they did great clinically, no relapses, some of them still lost retina, and when you did their exam, their disability scale, they were worse than when they started. So it may be telling us something about progressive MS. Yes?
Is there objective testing for OCT? And if so, what professionals provide this?
So, you mean objective testing, you mean who can do it, who can do the test?
Well, in other words, is there an actual scan to scan?
Absolutely. If you do it on the same machine, there are a couple of machine types. And it's not like an MRI where I can just put them side by side and I can almost, even though it may be a different machine, I can tell the difference. It has to be on the same machine. not the same machine in the same lab, it could be the same type of machine done across the country. But yeah, you can look because it just gives out numbers. It says your retina is this much microns thin or thick. And then if it loses 2 or 3 microns, you can measure that. Of course, it has to be more than the margin of error.
Is it an optometrist?
It's done at ophthalmology offices. A lot of neurologists have, like we have 2 research machines that we are now also using clinically. It's very easy. I've trained 3 or 4 different students to use it. Within a month, they know how to use it, they know how to do it. It's very easy to use. And it's not operator dependent, which is important. It's machine dependent, right? So operator to operator doesn't change the results that much. A couple more slides, I promise. We're almost done. So new ways to stop MS. What am I talking about? Stem cells. So when you mentioned, can we harness the power of the immune system? So when you hear stem cells, it's not as simple as just one fix for all problems. There's different types of stem cell therapies. One of them is to treat, actually go in and reset the immune system, and the other may be to go in and make the stem cell differentiate into the nerve cells and the axons in the myelin. Very different approach in how you do it. Because for the first one, if you've ever known somebody who's had a blood malignancy or some type of blood disorder, sometimes they go into a bone marrow transplant unit. They're locked in because they basically give them immunosuppressants. They wipe out their immune system. If you have to go in and visit them, you're wearing a mask, you don't want to give them an infection. And then they harness some of your bone marrow cells, some of the stem cells, they save them, and they wipe it out, and then they treat them and reintroduce them. So it's resetting the clock on the immune system. It works. It's been shown in a couple of studies to work in relapsing MS. The idea is when the immune system resets, it's not going to target the brain anymore. It has a lot of risks. The treatment itself is not that benign. You are wiping somebody's immune system completely. So it's not an easy fix. And some of these trials that have followed patients over time, it's not resetting the immune system in everybody. Some patients are having relapses. If you follow them long enough, they're going back to having relapses. So it may not be a fix for everybody. But that's one way to use stem cells. There's also another way where you're not doing any of that. You're just taking stem cells, you're treating them somehow, and then you're re-injecting them into the patient. And the idea is that they're going to go in and maybe just shift the immune response a little bit away from the brain, or they're going to promote some repair. They're going to differentiate into something, and they're going to go in and replenish that myelin or that nerve cell. This is a very optimistic point of view, but that's what they're hoping to do in these studies. It's been looked at several centers in the US and Canada. It has some potential. They've also derived stem cells from the placenta, and this study has just now shown safety. We don't know yet about more outcomes. They are trying to use more nervous system specific stem cells, so we know they're regenerating stuff in the brain. They're also taking cells from the skin, and they're going backwards, making them stem cells again. This way you're avoiding taking any cells from embryonic tissue. You're avoiding any of the ethical issues that come in with using embryo cells and things like that. And you're making those into stem cells that can go in and promote, manufacture nerve cells or myelin. 2 more slides about treating symptoms. So, fatigue. Everybody's now 10 times more fatigued than they were when you walked in here, probably. How do you treat fatigue or cognitive problems? For those of you who raised your hand, do you think your fatigue treatment works? If your leg isn't working so great, you can wear a brace, you can use a cane. It's not great, but at least you can overcome it. If you have cognitive problems, even if they're mild, if you can't do your job, that's an issue. So we and other people across the country are looking at different ways to treat this. This is a very interesting way. It actually promotes how the nerve cells talk to each other. Put a small electrode on the head. It's not painful. It's not electroshock therapy. You get a very small electrical current. You can barely feel it. You just feel like you want to scratch where that thing is for 10 seconds, and then you don't feel anything. While you're getting the stimulation, we have you do a cognitive exercise. So we're making you activate the brain part that's responsible for cognition. The idea is we're retraining it. It's physical therapy for the cognition. It's also been shown to potentially improve fatigue. So we have an ongoing study where we're looking at both. We want to see if it improves either. A group at Hopkins is doing a similar study. I think a group out of Europe is also doing a similar study. This has been studied in other neurologic diseases. Patients after a stroke have done better. It's been studied in a lot of other things, so it has very great potential. There have made machines that we can give you to do at home, so you don't have to come in for a study visit even, and you can do the exercise at home.
So,
Yes?
so how long would that last? Is that something?
So that's a very interesting question. You have to do it like for 2 weeks in a row, and we hope that it sustains for at least 6 months. So maybe you do it like once or twice a year, maybe even less often. But it's not something you have to do every day.
Okay.
And that's one of the questions we're trying to answer in the study, is how long does the effect last?
Right.
Lastly, medical marijuana. So I had to research this. I didn't know that there were 4 different types of medical marijuana. There's a pill with a cannabis extract. There's a synthetic pill, so it's not even made out of the natural plant. And this one is the one that patients who have cancer use the most. There's an oral spray, and then there's the natural oils and plant that you either smoke or you put in food. Which one of these has been shown to work in MS? It's mostly the pills. And they reduce patients' report of their spasticity. The doctor didn't feel that the spasticity was any different when you're moving your arms or legs, but you felt that your pain was better and that your spasticity was better. You may argue that maybe the doctor should take the pill and then re-examine it. We'll talk about that later. But basically, it's worth it. If it's a lot of these symptoms are subjective. There's never going to be a way we're going to be able to put a number on it. This was just recently the governor signed a bill for medical marijuana in PA. I'm sure you're going to have a lot of questions about it. We are already getting phone calls and emails, and rightly so, because people with even worse diseases need something like this. I did my research this afternoon just to figure it out, and they said it's going to take maybe like 12 to 18 months to even get it through the system. So we're going to see how practitioners are going to be licensed. They're going to have to open up dispensaries. So we'll see what happens. Questions? Yes.
You were a doctor of something called CCSPI.
Yeah.
What's the deal with that?
So a group in Italy thought that vascular congestion, because your blood drainage from the brain was not working great, that's what caused the lesions, and that's what triggered the inflammation. And to be honest, we don't know what triggers inflammation. If we knew, we'd know what causes MS. And so they went in and stented some of those venous sinuses, and they showed positive outcomes. A study done by the MS Society, sponsored specifically to answer that question, showed, at least last I heard was the early results. It didn't show any effect. So it wasn't replicated by anybody, and it's almost fallen off out of favor currently. Still, you can still find people who are willing to do it, but it hasn't shown efficacy. Any other questions? I know I've taken plenty of time. Thank you very much for your time.
All right, thank you everyone. I just have a quick question for you. Who are the top 2 funders of MS research in the world? You are. So you as the American taxpayer fund about $110 million worth of MS research every year. And if you take part in any of our events or you donate to the MS Society, then you're the 2nd largest funder by a long shot, which is up about $53 million. So all the progress that's been made is because of you. You should take pride in it. And we also encourage you to come out to our upcoming fundraising events, more programs like this. If you have questions,